Okay, can everybody hear me now? So welcome everybody. Thank you for tuning in. Those of us who are here now, punctual, right on time, and those of us to come. And of course, those of us who will see this later, we welcome you to this continuance of what we believe is a tremendous asset to our community, a program where we look to provide culturally sensitive education and ultimately uh, culturally sensitive healthcare nationally. This is, of course, the end game. But tonight we have with us a gentleman who has become a dear friend, obviously a brilliant doctor, Dr. Yousef Zakharia out of the University of Iowa. And he's going to share with us some of the latest research Iowa has done on the data around clinical trials. We, by this time, I hope, are aware that our participation of specifically the Black and African American spectrum of cultures have been dismal at best in these clinical trials. And that's important because, as people have heard me say before, that we don't often participate in clinical trials, but then of course, soon as we have an ailment, we run to the drugstore. And then of course, unaware that that's called post-marketing study. So you're actually the biggest lab rat in that environment than being in a controlled situation where you've been informed and able to move into a safe environment with regard to a clinical trial. So I am going to ask Dr. Zakharia maybe to add a few more comments about himself while, and of course, what prompts his passion for the community, which is very visible to me as a colleague working at least at arm's length with him and his institution. And I'm going to pull up his slides and then we will begin.
Yeah, thank you, my friend Mark, and it's my pleasure to be here. I hope you guys hear me well. Great. Mark, would you be kind to offer me the sharing capabilities so I can share on my side? Mark? Can I share on my side? Okay. Let me see if I can share my screen. You must be seeing the beautiful campus of University of Iowa now, right? And I think now you are able to see my slides.
Yes, we can see your slide. Yes.
Okay. Okay, great. Oh, what did I do? Yeah, so good evening, everybody. It's my distinct pleasure to be here when my friend Mark told me about this. And by the way, I say my friend, and we never met in person, I don't think yet, Mark, right? But we've spoken over the phone multiple times. So when he told me about his activity surrounding this series, it got me excited really, because I think we together can do a lot in this field. And as Mark mentioned, I mean, it's obvious to everybody that there is not like, or I would say there is an obvious disparity when it comes to clinical trial participation. And this is the only way how we can close the gaps and how we can increase awareness and the importance of this topic. And so I applaud Mark and I applaud everybody who made the time to attend this conference this evening, because this is really an important topic. And the title here is Lab Rat or Life Saving. I actually had a picture with one of my patients who went on a clinical trial that said Lab Rat on his T-shirt. He came in with a T-shirt that said Lab Rat on it, and for HIPAA reasons, I could not share it in here. It's really not a lab rat when it comes to a clinical trial. I always tell my patients, whenever you have an opportunity to come on a clinical trial, please take that opportunity for two major reasons. A, it gives you extra lines of treatment options. And B, that's how we advance the science. So the title of my talk is Lab Rat or Life-Saving. What are the modern clinical trials really? So I'm Associate Professor of Medicine at the University of Iowa. I am the Phase 1 Program Director, and we will talk a little bit more about Phase 1. What does it mean? I co-lead the Genitourinary Malignancy Program here at the Holden Comprehensive Cancer Center. These are my disclosures, nothing related to this topic. So I hope to achieve the following from this 10 minutes. I'm gonna skim through my 20-minute slides quickly, and I would like to keep ample opportunity for us to have a discussion, because I like it to be an interactive way. And please stop me at any moment if you have any question. By the way, you are able to see my full screen, right? It's not, you're not seeing your pictures or the screen mode, the presenting mode, right?
No, we see your full screen.
You feel okay, okay, and you are able to see my arrow?
Yes.
Correct.
Okay, fantastic. Yeah. So I'm going to talk a little bit about what's a clinical trial, the different phases of clinical trial. I'm going to show some evidence of the disparities associated with the clinical trials, and including one of our recent publications. And I'm going to propose in some solutions here. And more importantly, I'm going to open this for conversation, really, and discussion. So we have three major phases, or actually even phase 4 is out there post-marketing, as Mark mentioned earlier, but these are the three major phases when it comes to clinical trial. The phase 1, basically, it's the very first step when we take a clinical trial from the lab, from the research with the scientists to the clinic. It can be a first-in-human clinical trial, or it can be repurposing of a drug that has been tested already for another combination, for another cancer malignancy, or it can be a new combination, you know, that has been tested in and approved in another malignancy, and we just needed to test it in this newer population. So typically, the phase 1 primary endpoint, if you will, is the safety and the tolerability, or what we call maximum tolerated dose. And then looking for some sort of a signal, efficacy signal. And then if that's there, basically it goes on to a phase 2 clinical trial. It can be a single arm, or it can be a randomized smaller phase 2 clinical trial, mainly looking for the efficacy of this drug or of this combination. And once we establish that efficacy signal, then it goes on to a large phase 3, which is typically hundreds of patients, typically randomized clinical trial, and nationwide or international, with the primary endpoint typically of to establish the efficacy of this clinical trial, or of this new combination in comparison with the older standard of care treatment. And if it proves itself to be effective and superior to the standard of care, the control arm, that's when it becomes an FDA approved agent, and everybody can get it anytime, anywhere. So this, in summary, the different phases of clinical trials. And there are tons and tons of clinical trials currently ongoing. I tell my patient, if you were to get cancer in your life at some point, this is the right time to get cancer, because the field is moving so fast, and there are tremendous amount of clinical trial. I took this picture out of one of the presentation pre-COVID era, when we used to be in person. I think at ASCO meeting or so. Forgive me, I do not have the reference for that, but I took it with my iPhone. And this just lists like the different combination of immune therapy-based clinical trial in different malignancy. You look here, like the liver, you have all these clinical trials, different immunotherapy combination, pancreatic cancer, colorectal cancer, non-small cell lung cancer, small cell lung cancer, melanoma, kidney cancer, urothelial cancer, all, you name it. In every and this is already a 2 years dated slide, you know, so much more of this. There are much more clinical trials ongoing than this, and this just to give you a sample of how crowded is the field really. So, and since the picture is worth 1,000 words, is that what the saying is? So I wanted to list here a CT scan of one of my patients who went on a clinical trial actually in the early days of immunotherapy. This is almost 6 years now. This was a patient who presented with bladder cancer, basically got chemotherapy, went on to resection, who got chemotherapy with a plan to get at the time, the bladder cancer was localized. So typically we treat it with chemo followed by resection with surgery. And by the time between finishing the chemo and going to the surgery, there was some delay that the patient basically, by the time got to surgery, the surgeon, urologist calls me from the OR, in the middle of the procedure while the patient is on the table actually under anesthesia. He calls me asking for like an emergency family meeting with the patient's family who were waiting anxiously in the waiting room, because the surgeon tells me that basically opens the patient's stomach and it's all infiltrative mass, big mass infiltrating into the surrounding bowels, and basically could not touch it. It's just infiltrating, it's impossible to resect. So this is not a common scenario we encounter after chemotherapy. But this was one of very few cases we encountered this. So after family meeting, basically we decided, okay, to close the patient without any operation, without completing the operation or abandoning the operation, and basically follow up with us as outpatient. So sure enough, patient ended up after surgery in my clinic and basically we're unresected. And we ordered the CT scan after patient fully recovered from that semi-operation, if you will. And there is this bulky mass that is sitting on top of his bladder, and along with smaller masses that we do not see in here. So this patient went on this clinical trial with a drug called Opdivo or nivolumab. This was prior to the FDA approval of this drug in bladder cancer. It was in very early stages, actually, of immunotherapy in 2015. And few months later, basically on subsequent scans, all these masses disappear. This is the patient most recent scan. This is in 2015, and this is in June 2021. And as you can see, this big mass here, along with other masses, I'm not showing them in here, it all disappeared basically. And all what is left, basically the bladder, and I can show you, this is a different view. You can see here in 2015, it's an ugly looking mass on top of the bladder. And all this mass basically disappeared, this mass in here. Now, in a retrospect, this patient is now in complete remission, and I just see the patient once every 6 months now with re-imaging scan and in complete remission. So when we think retrospectively about this, without this clinical trial, the patient would have been in a different world, because patient already received chemotherapy. And at the time in 2015, we did not have but chemotherapy as a treatment option for bladder cancer at that time. And the patient would have been basically, referred to hospice. We could not do anything. We can give you some milder form of chemotherapy with minimal response, and basically patient would have died basically in 2015. But as you can see, with this clinical trial, with this immunotherapy that became later on an FDA-approved agent, patient got it ahead of the curve, and now is enjoying a healthy life, you know. I did not mention here that the patient is wheelchair bidden from an older motor vehicle accident, and that's why you see the bone is all already messy here. But patient survived a motor vehicle accident like 30 years ago and has supra bladder caster, chronic bladder caster basically in place. So this is an example on how exciting these responses can be. I'm not saying like everybody responds to the clinical trial, absolutely not. But I'm saying there are patients who respond to these treatment options, and we ought to offer these options to all our patients equally. Everybody should have access to these clinical trials. This is another example of another patient, not of mine actually, on a clinical trial that we have open at the University of Iowa in melanoma, using intralesional injection. So you can see here on the left side, big bumpy mass on the scalp. And we are utilizing this newer agent. We call it intralesional injection, TLR9 agonist, we call it. That's a mechanism of action, toll-like receptor 9 agonist. So it's a new innovative treatment that we inject inside the tumor. It's not yet FDA approved. So this patient was referred to this clinical trial after progressing on multiple lines of treatment options that he received before. And basically without this clinical trial, no other treatment option the patient would have. And as you can see, 12 weeks later, all these lesions scarred out, and 24 weeks later, 6 months later, they disappeared completely. So this is another successful example on how important the clinical trials are for our patients. Gives you extra line of treatment option, and that's how we advance the science. Because all these new FDA-approved agents that we can offer now, anytime, anywhere, to our cancer patients, they have been through these clinical trials from the get-go, and they have proven themselves to be effective before anybody can utilize them for other cancer patients. So this slide's basically from the FDA website. It shows you the clinical trials participation in the United States, and breaking it down in all clinical trial according to the different, you can see different colors in here, with the white color, the blue color, the African American are in the red color, and the Asian population in green color here. And you can see clearly there is a clear disparity within this this pie chart, if you will. And if you look specifically for the oncology clinical trials, you can clearly say the black colored or the black population is not as well represented in this pie chart. We want that to be much higher participation. It's a critical thing that we need to educate our population about. So this is a recent,
Dr. Zakharia,
I'm sorry.
Yes. Can I interrupt right there? And I know, my apologies, I don't want to continue to interrupt very much. I certainly want to continue, but I mean, I want to highlight some very, very distinct aspects of what you just spoke about, just in an aggregate sense. And as you mentioned, clearly clinical trials may work for some people, sometimes they do not. But of the summary that you've said thus far, you've highlighted and shown literal examples of your clinical practice where there have been people who had no other options available to them. So it wasn't like, and you correct me if I'm wrong, please, it wasn't as if these patients had an option of therapy that was guaranteed to save their life anyway. In this case, these patients didn't have other options. And because of the existence of the clinical trial, which goes through phases of validation to ensure that the mechanism of action and that the intent is probable, that the idea that being treated with this could in fact save your life, that in these cases, the patients were able to come onto a clinical trial and be treated, and in fact, their lives were saved or at least extended as a product of having access to this trial. Have I summarized that correctly?
I think you nailed it very nicely, Mark. You basically summarized what I said in a very nice and easy way to understand. Yes, when our patients come to us, well, two points I wanted to make here. Clinical trial does not always mean you are at the end of life. This is a misunderstanding of a lot of our patients, that if I am going on a clinical trial, that means I do not have another treatment option. No, that is wrong. As I mentioned earlier, we offer you a clinical trial to increase your treatment options. We might have other options down the road, but we can save them. We can save those bullets for later, or if you do not have other clinical trial available for you, then you can save that FDA approved agent for later on. And Mark mentioned it clearly that even with that FDA approved agent, there is no guarantee that one will work for you. Or for the patient, obviously, I'm saying here. There is no guarantee that FDA-approved agent is going to work for our patients. So that's one thing. So the clinical trial can be in a second-line setting, third-line setting, even with more treatment options available down the road that are FDA-approved, or it can be, like, especially when it comes to a phase 1, like first in human, it can happen after progressing on the standard of care options that are FDA approved. So it can be either or. So the clinical trial does not always mean you're reaching the end of the line, actually. We have many clinical trials, especially when they are phase 3, for example, they are actually first-line treatments, or even what we call sometimes now neoadjuvant clinical trial, meaning prior to the surgery when the tumor is really very localized to the primary organ. So these are very important points that Mark illustrated, and thank you for explaining that. And by all means, you are not interrupting. Please feel free to stop me at any moment, because I want this to be a lively discussion. So this is a recent publication that I had the honor of participating in, along with many colleagues across multiple other institutions listed here, and in collaboration with Pfizer Pharmaceutical. Basically, we looked into the demographics of the different clinical trial, phase 1 clinical trials that are published in literature. And the title of our paper was "The Race and Ethnicity Representation in Clinical Trials, Finding from a Literature Review of Phase 1 Oncology Trials." So basically, we went back to literature, multiple, the Google of medicine, if you will, websites like PubMed, Midline, Embase. So we isolated all these different phase 1 clinical trials in healthy and in oncology patients. Basically, we came up with 3,500. We set up some. We removed the duplicates. We ended up with this, like, duplicates, meaning like longer term, like, let's say clinical trial was published first with a preliminary results, and then there was a longer term follow-up on this same clinical trial. So this is a duplicate, for example, So we narrowed it down to about 1,400 trials, and we set up some inclusion, exclusion. Long story short, we included in our paper 374 clinical trials that we examined. And then in looking at the different participants here, in all participants, almost close to 10,000 people actually participating. Of those, 9,500 were patients. The rest, were healthy volunteer, because, in phase 1 clinical trial can happen in healthy volunteers too. And clearly, you can see here, this is worldwide, basically, clinical trials. 62% of patients or participants were Caucasian, 4% were African American, 30% were Asian. Because remember, this is international, so a lot of patients from Asia, from China and Taiwan, and so it's sizable their participation. And then the rest of the world, you can see minimal. Hispanic, Latino, 1%, 1.2. This is by all means not acceptable, you know. If you focus on the United States, these are the US patients, 84% of them are white Caucasian, 7% are African American, 3.4% are Asian. This is just the United States, and the rest you can see here. So clearly there's a lot to do. Why is this important? This is important because cancer does not recognize the color. Here I show you this from cancer.gov, the number of new cancer cases and deaths each year per 100,000 persons by race and ethnicity. The blue color male, female, red color. The solid is the new cases, and the dashed or the striped one is the deaths, number of deaths. You can see here in the white color, like 488 per 100,000 patients. In black, you have more than that, 535 new cases, and 239 per 100,000 deaths related to cancer. So it's not like we do not have enough cancer patients in our black population or in our Hispanic population. Absolutely not. Look at the female, same thing. The numbers are there, but it's for some reason, and I think majority of us know what are these reasons. Lack of resources, lack of education maybe, or whatever, those other different reasons. Our minority, there is a minority participation when it comes to African American or Hispanic, or let me call it the non-Caucasian population. So I don't think this is a news to everybody, but clearly there is a big problem and we need to fix it. So in other words, when we talk about equality and equity, basically this nice definition, if you will, or statement, I like it. It says everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environment, and healthcare. So it summarizes it all within this definition. So there is clearly a matter of resources, having access to resources that we're dealing here with our clinical trial. The words equality and equity are majority of times are being used interchangeably, yet they do not necessarily, or they do not have the same meaning. I like this cartoon with the apples and the kids. It summarizes it in a nice way, in a simple way, actually. So equality, basically it means to treat everyone the same. So clearly in this first picture here, we see there's inequality here because these two kids have access to different amount of apples on the tree. The tree is tilted towards this lucky kid, you know. And equality in terms of health, meaning it means to treat people equally, or to treat people equally would mean to give everyone the same type and amount of resources. However, equity is to treat everybody fairly. In other words, when you treat people equitably, it would mean to ensure that every individual is given the appropriate amount of resources that they need to achieve their health. For example, in this picture here, in the second picture, so you can argue these people are treated equally because both of them are given the same tool, which is equal size ladder. But still, this lucky kid had more access to the resources than the other one. When it comes to equity, when you are giving those people the amount of resources that they need to achieve their goals or their health. Basically, here you gave them equitably. You distributed the tools with the ladder equitably. You gave this kid larger or taller ladder in order to reach the tree. But are you treating them equitably? No. So how do we achieve that equality? It's basically by in this fourth picture, basically fixing the system to offer equal access to both tools and opportunities. And as you can see here, by fixing this tilted tree, offering them equitable ladders and fixing the whole system, basically is the right way to fix the problem here. So what can we do? Yes.
Once more again, please go back to that slide. I think that is, if everyone here, if with your permission, I would like to share at least that slide with everyone here, or I encourage you to go back and watch this and record it. I think this is such a very powerful cartoon. And if I may embellish a little bit, Dr. Zakharia, just small interruption. When we have conversations among ourselves in our barbershops, in our churches, in our homes, we have this conversation, and some of us don't quite understand these very important distinctions. As Dr. Zakharia very carefully pointed out, you could see the abundance of apple availability on one side of the tree and how the tree is bending to the left. And certainly when you're talking to maybe non-Black or non-Hispanic populations, some people might feel that no, everything is the same because in society you have these programs that maybe help, you know, Black and African American communities. So for example, at the top right corner, you see both people on a ladder. And then some people have a really difficult diagonals, that being the equality and the equity. Because when you talk to some people, they say, well, you both have a ladder, so we both should be doing equal in society. That's very well not true. And as Dr. Zakharia is pointing out, and into the bottom left corner, you see this equity where the ladder is a little higher for the person who have fewer apples. That's problematic for a lot of subpopulations in America. They say, well, you know, why are you giving all these resources for people? Because they don't understand that the systemic injustice, the systemic problems that you can see kind of culminate in the bottom right corner there, where the tree is upright. There's equal amount of opportunity for people who want to climb that ladder and work hard and achieve that apple. I think this is such a strong cartoon, and I really appreciate your sharing it, Dr. Zakharia, but I'm encouraging my brothers and sisters on this call to think of this, internalize it, and certainly take it back to your organizations and have.
Absolutely. Thanks for the illustration, Mark. I totally agree with you. So it takes a village to fix a problem, obviously, but it always starts from ourselves. You know, it's easy to blame things on the surrounding, but it takes us, as Mark clearly said, like, we need to climb the ladder ourselves, but at the same time, we need to have equal share of these opportunities and resources. So it works both ways. So a lot of education is needed in this regard, basically. So what can we do? I think education is the right way. Like, if you have a neighbor who you know diagnosed with cancer, ask them to ask their provider or their physician about clinical trials. What options are available for me? Even if I cannot get it here, can I travel somewhere else to a next big academic center to have an access to those clinical trials? Look up on clinicaltrial.gov. There's a very resourceful website, clinicaltrial.gov. I'm happy to write it down in the chat box later on. that can basically list all the centers where you have surrounding centers by you, where you can have access to clinical trials. Raising awareness in the community, in the churches. Again, I applaud you to distribute this in your communities, in the schools, starting from the children. You know, we have all these kids in high school. Educate them. Like if you have a father, mother, uncle, aunt, grandfather, brother, whoever, any family member has cancer, please educate them to have access to these clinical trials. Cancer, I tell my patient, cancer does not mean the end of life. It's a beginning of a new life with a new commitment. It's a beginning of a new life with a new commitment. Basically, it's just, I mean, we have a lot of our patients who are living their normal life. They just need to come every 3 weeks to our cancer center to get their infusion and go home and resume. I mean, obviously, I say this a little bit bluntly, but for some patients, that's a real lifestyle. Basically, they are feeling great, enjoying their life. They are tolerating their treatment well. They just come, show up for a couple hours infusion. They go home. See you next month or so. So that's how it is happening. When few years back, these same patients would have been dead without access to these newer treatment options. So that's why I tell my patients nowadays, cancer is not the end of life. It's a beginning of a new life with this commitment of coming to the cancer center to get treatment. Seminars, having these type of seminars like this, again, Mark, I cannot thank you enough for raising awareness of this in the community. These type of seminars or attending like the national meetings, ASCO, there is like patients advocates for ASCO, American Society of Clinical Oncology. For each society, basically, there is a patient advocacy. I encourage everybody to participate heavily in that. Like in kidney cancer, there is this nice kidney can association, if you will, or organization that is all patient-centered. It's all run by patient advocate. We just had our meeting a couple of weeks ago in Philadelphia, very nice scientific meeting, presenting all up-to-date, research, well attended by scientists, by patients. So I encourage you to take a role in that, spread the word, to take a role in this patient advocacy network, if you will. And there is network for every cancer. There is a bladder cancer advocacy, kidney cancer, prostate cancer, you name it. And there are multiple like online social media, all these web pages, Facebook, Twitter, you name it. There are tons of pages out there, and patients are willing to help each other. And believe it or not, patients will take in my experience or my observation at least, patient will trust another patient even more than they trust their provider potentially, because they are getting it from the patient, from their peers who are experiencing the same potential side effects that they might experience, So those patient interaction are really critical and very important and powerful. So I encourage all of us to take advantage of those networking possibility. Marketing, advertising, YouTube. Sure, you're listening. I mean, you get all this advertising on McDonald's and whatnot on YouTube. Why not listening? Like, if you are a cancer patient, ask your provider about clinical trial or on TV shows or something like that. It takes a lot to spread the word out, and it is critical to make this visible to everybody, because again and again, I still have patients in this day and age come back to me, and when I talk to them about clinical trial, their first reaction, oh, I do not want to be the guinea pig. And it takes me another half an hour to explain to them why a clinical trial is not simple as a guinea pig or a lab rat. No, it's way beyond that. And in order for us to reach this point where we're offering this drug in the clinic, whether first in human or on other clinical trials, it would have been vetted by many committees, by IRB, by PRMC or scientific committee, by the FDA itself. Too many committees have vetted the ethics, the safety behind this, or the ethics behind this clinical trial, whether it's ethical to be conducted or not, whether it's going to be safe for our patients, whether it's going to be promising for our patients or not. So it has been vetted through multiple committees in order to come available for our patients in the clinics. That's number one. And number two, it would have been through years of research. For a drug, it takes any drug to develop, like from the lab to the clinic, 10 of years it takes, without exaggerating. Majority of the drugs then take 10 years, in order to show up in the clinic. Medicaid and full coverage of clinical trial. I sit on this ASCO advocacy committee, and one of the recent asks when we meet with our state's legislative, one of the asks was to ask to allow Medicaid patient to have access to clinical trial with a full coverage. Apparently, if I understand it right, Medicaid patients or Medicaid does not fully cover the clinical trial cost. So that was one of the recent asks for when we met with the legislature earlier last year or earlier this year. So as we all know, Medicaid, there's a huge opportunity there. A lot of our Medicaid population are the underserved population. They need to have access to these equal opportunities or equitable and equal opportunities for clinical trials. So I like this slide. The best time to plant a tree was 20 years ago, but the second best time is now. So I think it takes all of us. It's a team effort. It does not only include the cancer doctor themselves. No, it's the patient advocate, the patient themselves, the family, the neighbors, starting from high school, educating those kids, plant it in their head. Like you need to ask about the resources, the access to the clinical trials if you have a family member that is sick. And this does not only apply to cancer, applies to everything else, every other disease. There are many other diseases that are not curable yet. And there are many new treatment options that could be available on clinical trials. So we encourage everybody to participate in that. With that, I always like to finish my slides with a picture from my home country, Syria, in case you were wondering where is this accent from. So this is a picture, nice sample of my country. This is a castle that is only 20 minutes from my house where I grew up in. I used to see it on the top of the mountain. It goes back to the 4th century. This is a monastery, an older monastery. It's under the ground, and you can see the newer one is on top. It's in the same area. Both of them are only like 15, 20 minutes from my house. This is the Umayyad Mosque in Damascus. That's where I went to my med school in Damascus University. So this is a beautiful mosque over there. This is a Mediterranean Sea. You can see it's a beautiful country, but unfortunately, it has been destroyed all over with the war. So I share this with my audience to tell them, like, this is a real Syria, not the one you see on CNN. With that, I would like to thank you, and I will open it for questions.
Thank you so much, Dr. Zakharia, for that wonderful presentation. And like you said, it's wide open. And of course, I'm going to throw my big mouth in there and make at least one quick comment right now. And then I'll pass it over to Lisa, who seems to be ready with her comments. I really want to applaud that suggestion he made, starting in high school, sharing this information throughout our community in high school, which apparently seems to be a novel idea lately, but certainly helping our students starting at a young age become educated about health and access to it. It's a great idea. So with that, I'll pass it to Lisa, and anybody, please jump right in. Now's the time to tap into this great wealth of experience.
Yeah, thank you, Mark, and thank you so much for the presentation. Very informative, inspiring. The slide that
Thank you.
Mark landed on with the equity to inequity or inequality to justice was very key. I have a couple of questions around the phases of clinical trial and enrollment. What I
Sure.
noticed was that you showed the FDA data around phase one. I'm curious about enrollment statistics around phase two and phase three. And I'm curious because I want to understand access to phase one, phase two, phase three. It would seem everybody should have access to all clinical trials, but I know that there's criteria that has to be met for being enrolled in a clinical study, right? So
Right.
I want to have more understanding around that, phase one, phase two, phase three. What does that look like, and how can we? Yeah.
Sure.
Okay.
If I understand you, thank you for the great question, Lisa. So if I understand you correctly, you are referring to this slide?
I was actually, yeah, yes, and I was referring to the one prior. Go back one more where you showed participation, where you did this study, right? It was all based on phase one clinical trials.
Correct. Correct.
Yes, you had not, it wasn't phase two, phase three.
Correct. Correct.
Okay.
So this slide here by the FDA includes all the clinical trials, whether phase one, two, or three.
Okay.
Basically, our
Okay.
study that we did basically was focusing on phase one clinical trials.
Okay.
And to your comment earlier about the eligibility, yes, every clinical trial has a strict criteria, inclusion and exclusion criteria we need to meet, in order to have access to that or qualify for this clinical trial, simply because this is a newer agent that is being investigated. So we wanted to make sure we are picking up the right patient for the right trial, and it would be, at the end of the day, safe for that patient. For example, one of the usual criteria, they should have healthy bone marrow, for example, as reflected by their white count, red blood cells, hemoglobin, hematocrit, and platelets count. They should be above certain level. Some trials mandate that you should have a good function of your heart, ejection fraction of the heart. So there is a long list of criteria, a checklist basically, that our coordinators and the provider or the physician go through one by one to make sure that we are choosing the right patient for the right trial. And at the end of the day, it's safe for that patient to be on this clinical trial, because safety is first.
Okay. In follow up to that, I'm thinking about, most patients want the best outcomes. And in order to get the best outcomes that apply to you and who you are, woman, female, African American, certain age, you have to be represented in clinical trials. At your university, do you have marketing materials or resources that are geared toward the enrollment of and recruitment of African Americans? And if so, how do we get access to those types of materials?
Yeah, that's a great question. I have to say, we live in Iowa, so the African American population is not as common, obviously. So that's one of the things we lack here. Actually, is our representation in clinical trials typically is not as high as Georgia, let's say. So this is a missed opportunity, if you will, here. But I don't, at least at my center, I'm not aware of any like certain brochures or materials that we distribute specifically for certain race or ethnicity. It's basically available for everybody. I'm not aware of any clinical trial, at least that I have been a principal investigator on that says, oh, you have to be a white or African American or Hispanic. There might be certain disease specific, like sickle cell, let's say, or something like that, which is much more common in African American. I wouldn't be surprised if there is a clinical trial geared towards like certain ethnicity to understand the mechanism behind it in that specific ethnicity. I wouldn't be surprised to see such a clinical trial, but these are not the norm. The norm, all the clinical trials are available for everybody, and hence we do not have like material specifically that is shared with African American only, or with white, or with Hispanic, or male, female, or whatnot. Nothing is geared toward that. I would say it's just education in general, educating everybody in general, your neighbors, your church brothers and sisters, your colleagues, your school kids, everybody being educated to understand about clinical trial and read about it, know what it has to add. I think that's a way to go, as opposed to selectively target, like with the brochures, or like this brochure is for my African American population, or for my white population. We do not want that to be evident too. We want it available for everybody equally and equitably.
So inclusivity is great. I think though there's got to be a way to reach. And I think if you're saying that reach is through churches, through the barbershops, through beauty shops, but I think that the types of brochures that you have and who's represented on your brochures will get a greater sense of participation from a minority that's represented at 2% of your population that's not enrolled. Partnerships with the National Medical Association, just different ways to reach that. I mean, because I think it was apparent in your presentation who's lacking in these clinical trials. While everybody's
Absolutely.
important, for equity, I'm looking for the same opportunity and my ladder to reach
Right,
where it's
absolutely.
to reach there. So
Absolutely.
I love the inclusiveness of what you say and not leaving anyone out. So, but I hope that we can identify ways to also touch that 2% or 3% and grow it to 10 to 15%,
Absolutely.
Yeah.
Absolutely. And that's why we are meeting now at 5 p.m. or maybe 6 p.m. your time, Eastern time, right?
Yeah.
So because we need to increase this awareness, we need to educate our population, and basically, that's how we do it. I mean, without this, basically everybody will be living in their silos, and no communication, no networking will happen, and basically that 2% will never increase. But whatever Mark is doing, and all the attendees here, and hopefully whoever is going to listen to this video, hopefully will find it a useful material to spread the word out there. That it's a word of mouth. It does not take more than a word of mouth, believe me. It's and educating people about it.
Very useful. We will spread the word.
Yeah.
This is Pastor Hamlin for Second Baptist Church of Doylestown. I want to thank Mark and Dr. Zakharia. We thank you for the presentation and information. I just wanted to interject, as you were talking about having African-American clinical participants, and we know that there are not many. I just wanted to share, I recently lost an aunt just over the past month, and she had throat cancer and had been involved in clinical trials for over 10 years. And that is what has kept her, these various trials that she went through. So as you were saying that, I could certainly raise my hand and say, well, listen, I've seen it in action. And my aunt survived about 10 years. She was, they said that she wouldn't make it 10 years ago. She started the clinical trials, various medications, and she lasted another 10 years. So I'm grateful and thankful, for that.
That's amazing and fascinating story. Sorry for your loss, first, Pastor Hamlin, and it basically excites me to hear that our patients lived longer 10 years because of clinical trials, because that's what I'm passionate about, and that's what I do for a living. That's why what keeps me going on a day in and day out. I mean, it's depressing to deal with cancer, no question about it, whether you are a family member, whether you are a provider, but it excites me the most to see my patients responding to these treatments and to this clinical trial. I think it's a great. So thank you for sharing your experience.
So, J Doc, it seems like I see your screen light up. Do you have a question?
That's
comment?
Me, actually. J Doc is.
Okay. I was wondering, like, it lights up. I don't know. Okay.
That's my iPhone, because
Gotcha.
I'm using this, so
Okay,
it's for
gotcha.
a clearer voice.
All right. Yeah. Well, I tell you, in the last 4 minutes we have here, I want to illuminate a few things. Firstly, I want to thank Dr. Zakharia again for taking the time. I understand you have a family commitment to run to at 5 o'clock your time, and we really appreciate your squeezing us in this. As you spoke about earlier, we have not met in person, but we've began working professionally. Certainly in my role in the biopharmaceutical world, and was able to recognize mutual interest in specific needs of patients and communities. I want to thank you all for your comments. I want to illuminate also the distinction that Lisa and Dr. Zakharia was having with regard to the information to the patient. I mean, Dr. Zakharia is a clinician, right? So he cares about all his patients, of course. But, certainly to the point that Lisa was making, as evident as we all here, each of you are leaders in some way within the community. And that's when it comes our job, it becomes our job to maybe create those pamphlets and pieces of material that might be in Spanish or might be with the right imagery on the brochure, so that people in our community, when they see it, they can feel that affiliation and feel that communication. Or it may be through the leadership of someone like Dr. Hamlin, who's standing before a congregation of people who understand and trust him as a leader, and with his testimony explaining, here is the value of this. And then lastly, not because I'm ashamed to plug it, but Berea, right here. If in the event you find organizations or people in our community who have questions or doubt, or we do know there's a great deal of mistrust even after a great deal of education because of just what has happened in history. And people are here when you hear from grandma or you hear from uncle, that sort of weighs a little bit more than any of us here. But maybe by educating ourselves to how things have advanced a bit, what type of things have been put in place to sort of prevent some of the things we've seen in the past. We're going to make certain we have more platform here to have those discussions as we'll continue to do here. So I want to thank each and every one of you for coming and joining these. Obviously, we're going to continue. One last thing I'm going to announce, and I hope I'm not speaking out of turn with some of the people here, certainly specifically including Reverend Dr. Hamlin here. Dr. Hamlin, and we've selected 2 other states where we will be rolling out the Berea kiosk, and I think most of you are familiar with what that is, and we're going to learn more about what that's going to mean in terms of bringing doctors like Zakharia and others directly to you with very close portals, so that you can get access to information like this that's culturally sensitive to you. And there will be a whole lot to come there. That's going to be rolled out in January, so stay tuned. So without further ado, I want to thank you all again. Thank you, of course, in particular, specifically, Dr. Zakharia, for your time this evening. Thank you for that brilliant presentation. I want everyone to have a fantastic and blessed evening. Okay.
Thank you so much for the opportunity. Thank you, everybody, and I look forward to meeting you in person someday.
Thank you.
Thank you so much.
My pleasure. Have a good night.
Thank you.